Thank you. Hi, everyone. Samantha Burnham from Eli Lilly. First of all, thank you to all the speakers today and all the workstream members. Really great work. Suzanne, I've just got a couple of questions for you, more clarification, and I'm sure if I read the paper, they'd probably be in there. I noticed you talked about sensitivity and specificity for AD, and I just wondered, do you have recommendations for the standards of truth for these biomarkers? And if so, would PPA, MPA, PPV, MPV for amyloid positivity, for instance, be a better representation? And are you thinking about tau as well as amyloid? And secondly, or an additional one to that is also you talked about CSF, and so how well the blood does in terms of CSF. Is that a direct comparison to CSF, or is it like a triangle up to PET? And my final question is, you said that these blood biomarker tests, if you use 2 thresholds, may get to this 90%. That obviously comes at a cost of an indeterminate window, and I wondered if you had any recommendations on what would be acceptable. Thank you.
Wow, those are great questions. We spent hours and hours talking about all of those questions that you just mentioned. So let me see if I can remember all of these questions. So in terms of sensitivity and specificity of the test, that's what we are talking about with regard to the test performance, because that's something that the manufacturers can determine. But as you're alluding to, the actual clinical performance depends on the positive predictive value and the negative predictive value. The issue with that, using that as kind of an output, is that it depends on your patient population, highly dependent on your patient population. It turns out that if you have a symmetric, say 90% sensitivity, 9% specificity, and you have 50% prevalence of amyloidosis, that your PPV and MPV are actually 90% for both. So that's just the mathematics. So it works out, and it, also I should say that in the IDEA study, where they actually did do amyloid PET scans on kind of our target population, that there was a 61% chance, or 61% probability of amyloid positivity. So basically what we decided about PPV and MPV was that it needed to be about 90%. Again, high thresholds. So you were asking about the standard of truth, and that, again, is a very good question. Something that some people have misconceptions about is they think that amyloid PET is perfect. But actually, if you look at what we use often in clinical practice, it's a visual read. So a doctor looks at the scan, their criteria, and you call it positive or negative. And in many studies, when you look at that clinical read versus the really rigorous research read, the SUVR or the Centiloid, they only correspond, 90–95% of the time. And if you take the exact same amyloid PET scans and you process them in the same way, they only correspond maybe 95–97% of the time. So the point is, amyloid PET isn't perfect, CSF isn't perfect, but you can get to a really high threshold. Really, the way that Alzheimer's has often been defined is in terms of neuropathology. And so neuropathology is the real gold standard, and actually that's how the amyloid PET was validated for FDA approval. So the initial tracers that were FDA approved were validated against neuropathology. And then the CSF was validated against the amyloid PET. So you're kind of getting further and further away. For the blood, it seems reasonable to validate that against the amyloid PET. And the reason that we're using that is because we already have a model. So the CSF biomarkers that have been FDA approved used amyloid PET as their standard of truth. So when we're talking about developing a standard of truth for blood, it seems logical to use the same thing that has worked for CSF. So that's why we're primarily talking about amyloid PET, although the reality is that neuropathology is really key. And then, in terms of cognitive symptoms, Of course, I think most of us are aware that you can have your brain full of amyloid and have no symptoms at all. And that's actually quite common. Some of these new tests, the p-tau 217 in particular, we find has much higher correlation with symptoms than A-beta 42 to 40. And we actually have new markers. We just published a paper in Nature Medicine on a marker in CSF called MTBR243 that has even higher correspondence with tau PET and with symptoms. So again, the blood tests are getting better and better. And we think that we'll be able to come up with blood tests that better tell you not just whether someone has amyloid in their brain, but also whether they have symptoms. For now, I think that what we're looking for is something that's telling us whether someone's amyloid positive or not, because we're looking at amyloid-lowering drugs. If you don't have amyloid in your brain, these amyloid-lowering drugs are not going to help you. So that's primarily why we have, defined things in the way that we have. Certainly, though, other companies have used tau PET as inclusion, so you can get progressively more complex. So this is the first step. We're building the initial steps, and there's more work to be done, but we think this is an initial framework that we're relatively happy with. So I'm sorry. Those were a lot of questions, and I think I did my best. Thanks.